Your specialist programme of research excellence is looking at translational research in prostate cancer. You're looking at molecular markers and assessment of prostate cancer. Do you think that we will replace the Gleason score in the near future with more accurate biological markers?
Well, this is a dream that everyone has, but whether we'll replace the Gleason score in the near future, I doubt. The Gleason score has been around for quite a while, and it really has a huge impact on prognosis and response to treatment. So I think that I see molecular markers as more likely adding to the Gleason score, modifying the Gleason score, but probably not replacing it. I think we'll need both. But we're right on the dawn of the time when we're going to identify really important molecular markers that are going to give us clear information that will help us manage patients.
Do you think prostate cancer ultimately is a very predictable disease? We just haven't found the right markers to predict what the biology is.
I think prostate cancer is a very predictable disease. If you look at our ability just using standard clinical features, stage, Gleason grade, PSA, percentage of cores that are positive, amount of cancer in core, we can predict with incredible accuracy whether a man's going to recur after treatment, how long a patient will survive. You know, the recent nomogram for predicting prostate cancer survival after surgery for prostate cancer predicts with 92% accuracy just from the preoperative PSA level, the Gleason grade in the surgical specimen, and the pathological stage of the tumor.
Yep.
That's remarkable. I think breast cancer and colon cancer would love to have that level of predictive accuracy. So what we're looking at with modern molecular markers is to add to that, but we do pretty well with prostate cancer. It's more predictable than people often think.
You first published in 1999 with Michael Catan the nomograms. Do you imagine it would take off the way it has with all the evolutions of the nomogram, and patients and urologists around the world use this routinely?
Well, Mike Catan is an eminently sensible statistician. He really approached this, I don't know if you know his own story, but he developed lymphoma when he was very young and was treated at MD Anderson. Okay. And he kept asking the doctors, what should I do? And they said, well, you have to have radiotherapy. And he said, but what are the alternatives? And they say, alternatives, look, you need radiotherapy, that's the next treatment. And he said, you're not giving me any risk. What if I do? What if I don't? What are the alternatives with different treatments?
Right.
And that was just as he was starting work with us in the prostate cancer program when we first got our SPORE grant back in 1992.
Yeah.
And so when Mike sat down and said, we have all this data on prostate cancer patients, we have such a great ability to predict what's happening if we combine stage, grade, and PSA in the right way that makes the most statistical sense. And I think the point that he made, the principles of that were very important. He showed that you really need to do continuous prediction instead of grouping patients in PSA 0 to 4, 4 to 10, 10 to 20,
yeah.
by just allowing the PSA to be put in whatever the number is, continuous variables, you get much more accurate prediction. So it's the principle of the nomograms that I think has been so important. And other kinds of simple classifications are good and useful rules of thumb, but they don't have the accuracy of that kind of a model. It doesn't have to be, it's really a nomogram is more of a statistical idea than a particular form of that idea.
You're obviously an expert in open radical prostatectomy, and the traditional urologist thinking with T3 prostate cancers, most urologists, particularly in where I came from in the UK, would refer these patients for radiotherapy and hormones. But the envelope seems to be pushing towards surgery. What do you think will happen in the future with T3 prostate cancers?
Well, I do think we've discounted the possible role of surgery in T3 prostate cancers. I think we've made an assumption that these are incurable tumors, and honestly, the reason we've referred these patients for radiation and hormones is not because it's clearly better than surgery, but because we felt, we're not going to cure these patients with anything, so why subject them to the complications of surgery? But in the modern era, with so many surgeons skilled in doing prostatectomy, it's not all that morbid an operation. I mean, the risks are not high. Urinary incontinence, which everybody fears the most in terms of long-term problems, is pretty uncommon. It's no more common in T3 cancers than it is with T1 or T2.
Okay.
So the only big increase in morbidity is erectile dysfunction if you have to do a wide dissection around the nerves.
Yep.
But if a man gets long-term hormones and radiation therapy, his erectile function's not going to be very good. So I think we've begun to realize that not necessarily that surgery is better, but that it's an alternative. It's a different way of starting out the treatment that might make sense in younger men who are fit and healthy and can go through surgery safely. And it gives you the added benefit of having the ability to monitor the disease with the PSA. You take out the prostate, if the PSA goes to 0, you might not need to do anything else. If it doesn't or it starts rising again, you can give local radiation. If that works, you may be able to postpone hormones for many, many years, maybe for the rest of the patient's life.
In the US, certainly, the battle of the robots seems to have been won, or in some people's opinion. Do you think there will ever be a reverse and open radical prostatectomy will become the primary operation again for prostate cancer?
No, I think robotic surgery in one form or another is probably here to stay. There are many attractive features of it. It's sort of physically easier for the surgeon. It calls for a different level of manual dexterity, three-dimensional reconstruction than open surgery does. So it's a different group of talents that make you good at robotic surgery than good at open surgery. Some surgeons are very good at both, but some clearly are more skilled at one or than the other. So I think it's an advance that we have a tool that allows more than one approach. My guess is that in the States, robotic surgery is going to become so common that few surgeons are going to be skilled at open radical prostatectomy, and I think it would be a shame to have that technique die away completely, because I think there is a role for it.
Yeah.
And you don't know how surgery is going to change in the future. When I look back at the time I finished my residency program, one of my chief residents said to me, you ought to go scrub on a radical prostatectomy because they'll probably not be done anymore. They'll be totally replaced by radiation, and just for historical reasons, you should see one.
Right.
And then a few years later, Walsh started the nerve-sparing operation, and radical prostatectomy has taken off.
Took off, yeah.
So you don't know what are things going to be like 10 years, 20 years, 30 years down the road, and don't assume it's always going to be like it was during your training. So the more broadly you can train, and the more broadly you'll be prepared for the future.
Yeah. What do you like doing in your spare time? Or is the concept of spare time one you're not familiar with?
Well, Tony Costello was asking me the other day, how do you divide your time up between work and leisure? And I said, it's very easy. It's 99% work and 1% leisure. That's not really true. I love to play golf. I began playing when I was in my 40s when my son took it up, and he was 10 years old. So the family likes to play golf. My wife and I love that. We like to bicycle. We like to go on long walks. We like boating. So, whenever we can get away, it's a lot of fun to do it. But when I was in medical school, Gene Stead was the professor of medicine, and he used to say to us, if medicine is not the most fun thing that you're doing, you probably shouldn't go into it, particularly not academic medicine. And I just get a big kick out of it. I thoroughly enjoy the opportunity to ask questions, find new answers, and hopefully make treatment better for patients.